I am from Indonesia. I'm usually a journalist. I would like to present a case with the title Choledochal Kiss on 2-year-old Girl, a Case Report. Choledochal kiss, a swelling or widening of dilatation of the bile ducts. The exact cause of CCS is still unknown. Children, 80% develop in children younger than 10 years and still happen in adults. Female 4 times more common than males. The classic symptom, intermittent abdominal pain, jaundice, present of right upper quadrant abdominal mass. We present a case 2-year-old girl with choledochal kiss and pancreatitis as complication. This case underwent biliodigestive bypass, cholecystectomy, and cholecystectomy. Got total parenteral nutrition for 2 days and treated with intravenous antibiotic. There was improvement in clinical manifestation after surgery. A girl 2 years old and 5 months suffer with intermittent abdominal pain since 1 month ago. The pain has gotten worse since the past 15 days. Both eyes look yellow since 2 weeks ago, increased throughout the body. Vomit since 1 week ago, 1 until times a day, amount about 5 tablespoons until a quarter of glass of time. There was history of putty white defecation 2 weeks ago. The decrease of appetite during illness. Patient was referred from district hospital, diagnosis CCS type 1 based on ultrasound, treated with ursodeoxycholic acid and curcuma. Patient was the only child, orphan, had complete basic immunization, growth and development was normal, lived with her mother, grandmother, and grandfather in permanent house with good hygiene and sanitation, good quality and quantity of nutrition. On physical examination, general appearance was moderately ill and alert. Blood pressure was normal, heart rate was normal, respiratory rate was normal, and body temperature was normal. Body weight 11 kilogram and body height 87 centimeter. Nutritional status well nourished. There was icteric and anemic but no edema and cyanotic. The skin was pale and warm, jaundice all over the body. There was no enlargement of lymph node. The head was round, symmetrical, and normal sepal, normal house standard. The conjunctiva was anemic, sclera was icteric, and the pupil were normal. The chest and heart within normal limit. Abdominal examination not distended, supple palpated, liver palpated, and spleen was not palpable. Normal bowel sounds. On laboratorium, hemoglobin was decreased 8.7 gram per deciliter. White blood cell is increased and platelet was increased. Differential count was normal, but increase of liver function level, amylase, pancreatic, and lipase was increased. Bilirubin was positive too in the urinalysis examination, and feces examination, the color was pale yellow, other result within normal limit. On abdominal ultrasound, we found dilatation of intrahepatic bile duct, circular shape, suitable with impression of choledochal kiss type 1. This is MRI and MRCP in the patient. The gallbladder appeared slightly enlarged, no mass in the liver. The size of intrahepatic biliary duct was enlarged with the homogeneous signal intensity. The size of extrahepatic bile duct was enlarged with the homogeneous signal intensity. And conclusion, choledochal duct kiss type 4A, suitable to any classification. This is pathology anatomy of the patient. Gallbladder tissue found piece of gallbladder, greenish, cherry solid with greenish mucosa smooth, thick wall, macroscopic. And piece of gallbladder tissue like kiss with thick wall consisted of mucosa layer coated with epithelial columnar cell and grow forming crypts. Muscularis layer and loose connective tissue consists of capillaries and lymphocytes at mucosa microscopic. So conclusion was choledochal cyst. We give a treatment in the patient, nutrition, liver diet, 1,100 kilocalorie, treatment ursodeoxycholic acid and curcuma, and we give vitamin A, vitamin D, vitamin E, and vitamin K, antibiotic meropenem, and we consult the surgery department. Patient has undergone biliodigestive bypass surgery, cholecystogegenostomy, jejunojejunostomy, and cholecystectomy, treated in the ICU room, and got total parenteral nutrition for 2 days. Patient had no complaints and in stable condition. Plan to discharge after 38 days of hospitalization. This is an operation: biliodigestic bypass surgery, cholecystogegenostomy, jejunojejunostomy, and cholecystectomy. This is an operation. So we give a dietary in this patient. Our patient may benefit from formula rich in medium chain triglyceride or formula supplemented medium chain triglyceride oil. Restricting enteral fat intake is not indicated. In choosing enteral formula, standard products may be adequate. This could prevent essential fatty acid deficiency. Conclusion in this patient: a case of 2-year-old girl with choledochal cyst with pancreatitis as a complication has been reported. The diagnosis of choledochal cyst and pancreatitis based on patient history, physical examination, laboratory findings, and imaging modalities. So presentation: in clinical presentation, intermittent abdominal pain and icteric. The laboratory: increase of liver function level, amylase, and lipase serum. Imaging modalities: choledochal cyst type 1 from ultrasound, but type 4A from MRI and MRCP. Treatment: surgery and antibiotic meropenem for the pancreatitis. The result: no complication of surgery. So the patient is good after surgery. Nutritional diet: medium chain triglyceride, and prevent deficiency of fatty acid. So thank you very much. That's all my presentation. Thank you very much.
Conference. Let me introduce my presentation on difficulties in the diagnosis of mycobacteriosis in early age children without immunodeficiency. Mycobacteriosis, an infectious disease caused by non-tuberculous mycobacteria with the development of granulomatous inflammation in the affected organs and tissues. Non-tuberculous mycobacteria are a group of environmental, saprophytic, and opportunistic mycobacteria other than Mycobacterium tuberculosis complex. More than 200 non-tuberculous mycobacteria species have been identified. About 1/3 of the identified species are considered clinically significant. The table represents the classification of non-tuberculous mycobacteria by pathogenicity. Among slowly growing non-tuberculous mycobacteria, the most pathogenic are Mycobacterium avium complex, Kansasi, Xenopi, Gordoni. Among rapidly growing, Mycobacterium abscessus, Fortuitum, Heloni. The most prevalent non-tuberculous mycobacteria species worldwide is Mycobacterium avium complex. Habitat of non-tuberculous mycobacteria. Soils, especially acidic soils, thus derived from farming or gardening activities. Water from rivers, water bodies, swimming pools, drinking water, water aerosols, air humidifiers, ways of infection, airborne, alimentary, waterborne, contact transmission through a damaged skin. Human-to-human transmission is not typical. Mycobacteriosis, the disease commonly develops in individuals with local or general immunity defects, primary immunodeficiency, HIV infection, chronic pulmonary diseases, cystic fibrosis, long-term administration of immunosuppressive therapy. Non-tuberculous mycobacteria may cause lung diseases, lymphatic system disorders, disseminated lesions, lesions of skin or soft tissues, diseases, bones, and joints. Epidemiology. In the recent years, significant growth of mycobacteriosis incidence has been observed in all developed countries due to improvement of microbiological diagnostics, an increasing share of patients with immunosuppression or other comorbidities, which can be the risk factors for non-tuberculous mycobacterial infections. In Russia, non-tuberculous mycobacteriosis are not subject to official statistical registration, and it is impossible to reliably estimate the incidence and prevalence rates. Diagnostic of non-tuberculous mycobacteriosis, clinical presentations, and radiological changes caused by pulmonary mycobacteriosis or intrathoracic lymph nodes mycobacteriosis are identical to those caused by TB. Histological studies of affected organs and tissues reveal different degree granulomatous change, which can be referred to patterns typical for different variants caused by mycobacterial tuberculosis. The disease verification can only be done by microbiological methods. The detection of non-tuberculous mycobacteria in diagnostic samples using cultural studies or PCR diagnostics. The main diagnostic criteria for mycobacteriosis of the lungs. Clinical criteria allow suspected mycobacteriosis. The presence of respiratory symptoms along with radiological changes, nodular, cavitary, bronchoectatic, if other diagnoses have been excluded. Microbiological criteria allow verifying mycobacteriosis. Repeated at least 2 sputum samples, isolation of the same non-tuberculous mycobacteria species in the absence of other pathogenic microbes. Single isolation of non-tuberculous mycobacteria from the closed source obtained in sterile conditions, resection samples, biopsies, bronchoalveolar lavage. The presence of histopathological signs of mycobacterial infection in tracheobronchial or other lung biopsy and positive culture for non-tuberculous mycobacterium. Clinical observation. Mycobacterial infection caused by Mycobacterium avium with affection of the intrathoracic lymph nodes under the guise of TB in a 2-year-old child. The disease manifestation at the age of 5 months. April, May, July 2019, relapsing pneumonia. In patient treatment without notable radiological dynamics. Suspected TB. Diagnostic criteria for TB. Failure of treatment with antibiotics. Computed tomography of the chest. The pattern of intrathoracic lymph node TB complicated by telectasis. Bronchoscopy results. Multiple bronchonodular fistulas of the right upper lobar bronchus. Positive reaction to the Mantoux test. T-spot TB result unspecified. The child was not vaccinated against TB. The results of microbiological studies for TB using all methods were negative. TB treatment outcomes. TB treatment was administered in hospital for 14 months according to the clinical protocols. Low effectiveness. Chest computed tomography. The conglomerates of swollen intrathoracic lymph nodes on the right are preserved. Bronchoscopy. The bronchonodular fistulas are preserved. Referred to surgery. The intrathoracic lymph nodes on the right were removed. The results of the resection sample studies. Microbiological study. Microscopy studies revealed acid-fast microorganisms. The species was identified by PCR. Mycobacterium DNA was extracted. Histological study. TB-like granulomatous inflammation with caseous necrosis in the center. The diagnosis was verified. Mycobacterial infection caused by Mycobacterium with affection of the intrathoracic lymph nodes. Treatment after surgery. Scarce amount of diagnostic samples did not allow conducting drug susceptibility tests. The combination of drugs was composed empirically. The total duration of treatment after surgery was 9 months. After 9 months of treatment, closed of bronchonodular fistulas. 1 year after treatment completion, no relapse. We conducted additional studies in order to diagnose the underlying immunosuppressive disease. Conclusion. The diseases referred to primary immunodeficiency were excluded. Cystic fibrosis was excluded. Conclusion. Mycobacteriosis may develop in children without pathology accompanied by immunosuppression. TB and mycobacteriosis in children have similar clinical and radiological patterns which impacts differential diagnostics. Verification cannot be only based on histological studies. In both cases, granulomas with caseous necrosis in the center develop. The final verification can only be based on PCR diagnostic or cultural studies. Thank you for your attention.
The birth history was totally uneventful, as he did cry immediately after birth. There was no history of NICU stay. The baby was born to non-consanguineous parents, and there was no significant antenatal history in the mother. There was no history of preeclampsia, gestational diabetes, any leaking. The only indication for a cesarean section was a previous cesarean section, which made the mother a high-risk case, and hence
Sorry for the interruption.
Yes.
Sorry for the interruption, sir. Can you share your screen, sir?
Sorry,
We are not able to see your screen.
just a minute.
Yes, sir. Thank you. We can see. You can make it a full screen.
Can it be seen now?
Yes, sir. Can you please make it a slide share, sir? The right corner. Lower right corner has the full screen option, sir.
I have done the full screen. It's not there.
No, sir. We are just able to see is it as a whole.
Just a minute. Mhm. Now, ma'am.
Sir, it's fine now. You can proceed, sir.
So, sorry for the interruption. So, this was a 5-day-old male baby who was born at term gestation, 38 weeks, 2 days. He was born by lower segment cesarean section with a birth weight of 3 kgs. The birth history was uneventful. The baby cried immediately after birth. There was no history of NICU stay, and he was born to non-consanguineous parents. The mother had no significant antenatal history. There was no history of preeclampsia, gestational diabetes. She had regular antenatal health checks. Her weight gain was appropriate throughout the period of pregnancy. And other than regular iron and folic acid supplementation, she did not receive any other medication during her antenatal period. The family came from an upper middle class strata with a permanent house having good sanitation and hygiene. So the baby was not born with us. It was an outborn referral, and the baby was born somewhere else. And the baby came to us in the emergency ward with history of multifocal clonic movements of all 4 limbs, with each episode lasting 10 to 15 seconds. So as per the protocol, we checked the temperature, airway, breathing, circulation, and sugars. He was euglycemic. He was afebrile. The airway was secure, breathing and circulation were taken care of. He was loaded with injection. He was loaded with anticonvulsant. We gave injection phenobarbital, following which the seizure activity settled, and samples for neonatal seizures, which metabolic screening were sent. Supportive care was initiated, and he was shifted to the NICU. On examination, the anterior frontal was at level. The occipitofrontal circumference was 33 centimeters. Features of encephalopathy were present. There were no obvious neurocutaneous markers. Rest of the systemic examination was normal. So once he was stabilized, we had a detailed discussion with the parents as to what, and we had to ask certain questions to rule out certain exclusions or diagnosis. So the only complaint they came was on day 5 of life, the baby, he already had multiple episodes of seizure-like activity of all 4 limbs. So what they said was once it started with the right upper limb, then once with the left lower limb, and it was keep changing. There was no significant family history. There was no family history of seizures. He was on exclusive breastfeed since birth, and there was no history of stay in the neonatal care unit. So with this background, we did ask certain questions whether to rule out certain exclusions. When we saw in the emergency room, he was euthermic, but we did ask for any history of fever or any faulty feeding practices, which were none. There was no history of consanguinity, no history of repeated vomitings. We suspect even metabolic causes. So we asked inborn errors of metabolism. So we asked for repeated vomitings or failure to thrive. The birth weight was 3 kg and the child was 2.9 kgs. So the weight loss was appropriate to the age. And there was no family history of seizures. So in the NICU, he was managed as per the unit policy, and he had within 6 to 12 hours of admission, he had repeated episode of seizure activity, which were again focal clonic. So he was loaded with another dose of anticonvulsant. We give here levetiracetam, but despite 2 doses of 2 antiepileptics, his seizures continued, and finally we had to give midazolam infusion, following which his seizure activity settled. He was ventilated in view of repeated seizure activity for 48 hours. Hemodynamic monitoring and stability were ensured. So, with the diagnosis of refractory neonatal seizures with onset at day 5 of life, this was the child. we started looking at differentials. What could have exactly happened? So we thought of sepsis. Yes, definitely, because being a sepsis could be one possibility. Late onset hypocalcemia, other metabolic causes like hypomagnesemia, and inborn errors of metabolism. Although there was no history of consanguinity, sporadic cases of IMs can be possible. So with the above picture in background, we started evaluating one by one. The sepsis screen sent at admission was normal. The hemogram was normal. The metabolic workup, calcium, magnesium, electrolytes, renal function tests were within normal limits. The cranial ultrasound done during the course of NICU stay was also normal. We did consider a lumbar puncture was normal. The EEG done was normal, and pediatric neurologist opinion was taken. In the meanwhile, because he was labeled as refractory seizures, we did give 1 dose of pyridoxine just before giving midazolam infusion, a word which I forgot to mention previously. So pediatric neurologist opinion was taken, which showed this particular pattern on MRI. It showed a diffuse, symmetrical white matter and corpus callosum diffusion restriction suggestive of viral encephalitis. The white mark thing, if you can see, that is abnormal. So what viruses can do? Para-ecovirus and rotavirus. Now, we were in a dilemma. A 5 days old baby, otherwise normal, on exclusive breastfeeds with no history of consanguinity. Are we going on the right track? Is rotaviral encephalitis really possible in a 5 days old baby? So we were confused what to do next. So as the MRI picture was suggestive of viral encephalitis, with the above pattern, ADC radiating pattern, which is suggestive of para-ecovirus and rotavirus, we sent stool samples. So stool PCR for rotavirus was sent, which was positive. CSF PCR was for rotavirus was sent, which was negative, and CSF PCR for para-ecovirus was sent, which was negative. Now here comes the question: the CSF PCR was negative. Should we label it as encephalite? Should we? Is it possible for the virus to without enter? It's not detected in CSF. Is this possible? So with the probable diagnosis of rotaviral encephalitis, as the stool PCR was positive, we started looking at literature and previous observations. So then came this person. Then as we went through various articles and journals, we found this particular person, Hermann. He was a German scientist. He was a German doctor. He was a German physician who, as early as 1990s, observed a coincidental detection of rotavirus in the stools of several newborns presenting with 5th day of seizures. Again, this Korean study in 2016 also reported that white matter injury following rotavirus infection was possible. And with these 2 case reports and literature available, we started looking at various possibilities as to how rotavirus can cause encephalitis in the newborn. As we all know, rotavirus is a worldwide leading cause of gastrointestinal diarrhea. And now in India and mostly worldwide, we have the vaccination available for rotavirus. Previously, before pre-vaccination era, rotaviral diarrhea was a leading cause of death, with many children under 5 years of age dying because of dehydration and metabolic abnormalities and dyselectrolytemia. Now, with the safe availability of vaccination and awareness among the people, the mortality rate because of rotaviral diarrhea has decreased dramatically. Except for sub-Saharan Africa, rotaviral diarrhea has now, the mortality with rotaviral diarrhea has now decreased dramatically worldwide. So we know about the gastrointestinal tract manifestations. But does it cause any extraintestinal manifestations? Yes, sporadic case reports were there that it can cause neurological diseases, it can cause hepatitis, it can cause myocardial dysfunction, it can cause arrhythmias. The babies can present with myocarditis. It has even known to cause pancreatitis and acute tubular necrosis with renal failure in certain cases. But only a few studies done by Gomez, Herman, Crawford from the UK examined the association between rotavirus and neurological symptoms in newborns, specifically in newborns. So this study done by Crawford from the United Kingdom, what they saw was rotavirus associated benign convulsions with gastroenteritis in the pediatric age group. This was not in the neonatal age group. Febrile, brief, tonic, clonic to multifocal seizures can be possible between the first to fifth sick days of gastroenteritis. The possible mechanisms being the brain-gut communication directly leads to vomitings, the feeling of sickness, loss of appetite, and malaise. The direct CNS effects like direct viral invasion of the virus on the brain, entry of circulating mediators, and entry of circulating leukocytes, which cross the blood-brain barrier, can cause encephalitis and features of encephalopathy. The activation of brain microglia, which release reactive oxygen species and nitrogen species, which are toxic to pre-myelinating oligodendrocytes, can cause white matter injury. This was the hypothesis that was proposed by the Korean study in 2015. So, based on these facts and based on this literature available, we saw this word, the fifth day fits, being reported in various publications. So what was this word, the fifth day fits? It was introduced in the 1980s to describe an epidemic of neonatal seizures that occurred in the 1970s. The fifth day fits is where the onset of seizures occurs between the fourth and sixth days of life in otherwise apparently healthy full-term infants. The main findings being healthy term infants with seizures between 4 to 6 days of life. Gastroenteritis symptoms may not be observed in most cases, as in our case. He did not have any symptom. He did not have any symptom of gastroenteritis. So, rotavirus was detected only in stool specimens, another lead. We could not find the CSF PCR positive for rotavirus. It was a stool sample which was positive. There was no evidence of CSF pleocytosis. The CSF study was normal for us. Even the cell count was within normal limits. But the picking up point here is the characteristic diffusion weighted imaging pattern on MRI. This is very particular, the white matter injury and the ADC radiating pattern, which is very characteristic picture of a viral encephalitis on MRI. So with these main findings, we concluded that this child should have rotavirus associated leukoencephalopathy with these evidences. With this evidence, which was obvious in our case, healthy term newborn, absence of perinatal asphyxia, there was no other known cause for seizure activity. The seizure onset was between 4 to 6 days. Absence of symptoms or very subtle signs of gastroenteritis. The rotavirus was detected only in stool specimens. There was no evidence of CSF pleocytosis and the characteristic diffusion weighted imaging pattern on MRI. So thank you for listening to me audibly. I'll just show you the case report. So based on this, what we concluded was, uh, I think being in a tropical country, rotaviral infections are very common. Okay, this is our case report. We As soon as we get a baby with neonatal seizures on the fifth day of life with the above findings, we do need to keep rotaviral encephalitis or paraecoviral encephalitis in mind. There will be no other clue. The symptoms of gastroenteritis may be very minimal or they may be absent. So we published our case report, The Fifth Day Fits Aspects to a Forgotten Entity. So way back in the 1970s, 80s, and 90s, we had a lot of case report. We had a lot of cases, but very few publications were done. So we just wanted to enlighten you people on this forgotten aspect of the fifth day fits, probably because reason being rotaviral paraecoviral encephalitis, in our case being rotaviral encephalitis.
Thank you.
Thank you, ma'am.
This,
Our mathematical model with a computer support program for determining the probability of developing congenital pneumonia in premature newborns with very low and extremely low body weight. The introduction of evidence-based medicine based on clinical trials allowed doctors to use optimal patient management tactics. The need for a personalized approach with the use of preventive, diagnostic, and therapeutic interventions is made based on the available information about their effectiveness and safety. Creating clinical recommendations is impossible without processing and storing a huge array of information about instrumental and laboratory
audio is
research
not.
methods and the results of work, which requires the use of modern computer technologies. The purpose of the work: testing the power of mathematical model with a computer support program to determine the probability of developing congenital pneumonia in premature newborns with very low and extremely low birth weight. 226 premature newborns were examined in the Department of Anesthesiology and Intensive Care with wards of newborns and the Pediatric Department for Premature Newborns of the State Institution Republic Scientific and Practical Center Mother and Child. Children were admitted for treatment and nursing from 22 maternity hospitals and departments of anesthesiology and intensive care of healthcare institution of the Republic of Belarus in the period of 2017 to 2022. To develop a mathematical model, 113 premature newborns with congenital pneumonia, very low and extremely low birth weight, and respiratory disorder syndrome were observed in the first study group. Due to inability at the time of the study to recruit a group of preterm newborns with extremely low birth weight, respiratory disorder syndrome, and the absence of infectious disease to determine factors associated with congenital pneumonia, 55 preterm newborns with congenital pneumonia, low birth weight, and the absence of infectious disease were included as a comparison group in the development of the mathematical model. It was assumed that with the effective separation of groups with congenital pneumonia and different birth weights, at the next stage, the probability of identifying premature babies with very low and extremely low birth weight and respiratory disorder syndrome but without infectious pathology will be higher. This slide shows the anatomical and physiological parameters per term newborns participating in the development of a mathematical model. The criteria for making a diagnosis of congenital pneumonia were the presence of infiltrative shadows on the chest X-ray in the first 72 hours of life, clinical and laboratory data. Exclusion criteria: the presence of chromosomal pathology and genetic diseases, prenatally detected malformations, birth as a result of the use of assisted reproductive technologies. Statistical data processing were performed using the software packages Statistica 10 and Microsoft Excel. To determine statistically significant differences in qualitative value, the Chi-square method was used, or for the extra fixture test with statistically significant differences, the odds ratio was calculated with a confidence interval. The differences were considered statistically significant at p lower than 0.05. The red curve was constructed using the logistic regression equation. Based on their data, a computer program calculated tables with word variables, which allowed us to build a mathematical model. The model was selected based on sensitivity, specificity, estimated area under the ROC curve with the confidence interval, taking into account the calculated parameters of the double logarithm of the likelihood function and the measure of certainty. The power of the mathematical model was tested based on the result of sensitivity, specificity, predictive significance of a positive test result, predictive significance of the negative test result, and the likelihood ratio. For the purpose of practical use and calculation of probability on the basis of ROC analysis and the obtained mathematical model, the formula was used for the computer and maintains programs with the possibility to remote connection. To demonstrate the indicators and the possibility of mechanical calculation, a simplified modification of this formula is presented on the slide. To obtain high accuracy of P, we calculated all indicators and the maintains program only in the computer version. A comparative analysis of 10 factors of life history and outcomes of previous pregnancies, 12 complications of the present pregnancy, 5 histological examination of the placenta in mothers, and 187 results of clinical and laboratory methods of research in 168 newborns was performed. A comparative analysis of 10 factors from the life history, obstetric gynecological and somatic status of mothers was carried out in the form of spontaneous miscarriage, undeveloped pregnancy, vacuum abortion, medical abortion, chronic tonsillitis, chronic pyelonephritis, hypothyroidism, chronic gastritis, myopia, hepatic infection. This slide shows an analysis of 12 complications of real pregnancy: fetal intrauterine hypoxia, chronic fetal placental insufficiency, pyelonephritis of the pregnant woman, cervical erosion, fetal growth retardation syndrome, and change in amniotic fluid volume, preeclampsia, colpitis, acute respiratory infection, anemia of pregnant woman, isthmic cervical insufficiency, threat of termination of pregnancy. The results of histological examination of the placenta are presented on the slide. Out of 187 results of clinical and laboratory research methods, the most significant postnatal factors associated with the development of congenital pneumonia is preterm newborns with very low and extremely low body weight were identified. Respiratory failure several degree, asphyxia, hemodynamic disorders with hypotension requiring correction, laboratory findings as neutropenia or neutrophilitis, leukopenia or leukocytosis, neutrophil shift index, thrombocytopenia, and high C-reactive protein levels. Based on binary logistic regression taking into account factors as changes in the volume of amniotic fluid, changes in the placenta of inflammatory nation, respiratory failure, or hemodynamic circulatory disorders with hypertension requiring correction, changes in the content of the white blood cells, thrombocytopenia, high C-reactive protein level, a mathematical formula with a universal coefficient criteria is derived. The presence of high values of the negative doubled logarithm, the likelihood function, and the measure of certainty confirms the high statistical significance of the model variables. According to the table, the variables in the equation for preterm infants with very low and extremely low birth weight according to Wald are presented. The formula of the mathematical model with its 8 parameters is presented on the slide. The ROC curve of this model is presented on the slide. The sensitivity of mathematical model was determined to be 87.6%, specificity 85.5%. For the purpose of practical use and calculation of probability based on ROC analysis and the obtained mathematical model, the formula was used for a computer. A threshold value of p0.73 was determined at which sensitivity and specificity are most optimal. If the value of p-index is equal to or greater than the established threshold value, the probability of developing congenital pneumonia is high. Based on the ROC model, a computer support program has been developed which allows remote calculation of threshold values of mathematical model variables. To quickly enter the computer program, the slide shows the QR code. A computer support program was used to calculate the indicators of the mathematical model in digital equivalent. To test the power of the model, an additional set of 58 preterm newborns with very low and extremely low birth weight who were not included in the previously obtained model was conducted. The second study group consists of 37 premature newborns with congenital pneumonia, very low and extremely low birth weight, and respiratory disorder syndrome. The second comparison group included 21 premature newborns with very low birth weight and respiratory disorder syndrome. In this group of preterm infants with extremely low birth weight and respiratory disorders without infectious pathology were not observed. Anatomical and physiological parameters are presented on the slide. This slide shows the absolute and percentage values of indicators for determining the power of the model in premature newborns with very low and extremely low birth weight. The total percentage of predictive calculation of the power of the mathematical model in premature newborns with very low and extremely low birth weight, according to the result of the computer program, was 92.6%. Based on the result of external validity of the mathematical model in premature newborns with very low and extremely low birth weight, the following power parameters were obtained: the sensitivity, specificity, the predictive significance of the positive test result, the predictive significance of a negative test result, and the likelihood ratio. You can see it on the slide. Conclusions. Based on the results of the ROC analysis, a mathematical model and computer program of support were developed for premature newborns with very low and extremely low birth weight, with sensitivity and specificity higher than 85%. A clinical study was conducted to determine the power of the model for preterm newborns with very low and extremely low birth weight, with sensitivity equal to 0.95, specificity 0.90, predictive significance of a positive test result 0.95, predictive significance of a negative test result 0.90, and a likelihood ratio of 9.93, which indicates a high power of the model. The results of our study can be found in the article presented on the slide. Dear colleagues, thank you for the attention.
That was a very good.
Hello, everyone, and thank you for the invitation. I'm going to give you a quick overview of the type of research that we do in prematurity. Our lab is a translational AI ML lab that works on a broad range of clinical indications. And we use a broad range of different data types, including single-cell immunologic profiling, various other omics assays, wearable devices, and electronic health records. I'm going to primarily focus on prematurity because it is the single largest cause of death in children under 5 years of age, both in low-income and in high-income settings. Beyond prematurity itself, what happens during pregnancy has important implications for life well into adulthood. For example, it has been shown now that cardiovascular health of an adult depends on what happens during pregnancy, especially with preeclampsia. Similarly, there have been indications between overall fitness, there have been associations between overall fitness levels and prematurity. So it's very important to understand what happens during pregnancy and shortly after birth to optimize our health well into adulthood. For our big picture thinking, we are thinking about modeling all types of data sets that are associated with a pregnant woman, including both structured and unstructured data, to build holistic models that can simultaneously predict various morbidities both in the mother and in the child. I'm going to show you 3 specific projects. First, we'll go over our immunologic studies. Then we'll talk about how social determinants of health can affect biology. And finally, we'll talk about a new taxonomy for prematurity itself. For our immunological studies, we know that the immune system is striking a balance during pregnancy between immune tolerance and pathogen defense. Our goal was to understand how various cell types during pregnancy change, with the hope of using that as a reference to detect abnormal immune trajectories. In our first study, we had 18 healthy normal pregnancies that were enrolled in the first trimester. We had a blood sample drawn at each trimester, 1 blood sample postpartum. All of these samples were processed using CyTOF, which is a next generation flow cytometer, with the hope of building a normal trajectory for pregnancy. The dataset included all of these cell types that we manually identified in the dataset. Each dot represents 1 cell type. 2 dots that are closer to each other represent 2 cell types that are correlated across all time points, all patients. This is the unstimulated data measuring these functional markers in these cell types. This is LPS, an interleukin cocktail, and an interferon alpha cocktail. This shows the modular structure of the immune system. Various cell types and signaling pathways go up and down together, of course. So we put all of these into a machine learning algorithm that takes all of that data and estimates gestational age. Turns out that we can easily build a model that tracks with gestational age, and after birth, it goes back to normal. Here is our validation cohort. It worked pretty well. We also had 3 preterm individuals who followed a completely different trajectory over time. The next step for us was to integrate that with data from other omics platforms. We had a cell-free RNA data set, a plasma proteomics dataset, a metabolomics and dataset, an immunome dataset that you already heard about from CyTOF, microbiome analysis of 5 different body sites, and plasma and serum cytokines. Putting a large dataset like this together in a machine learning algorithm is not an easy task to achieve. If you try to see what correlates with what, you end up with a correlation network like this. Not particularly helpful, so you have to go back to more systematic predictive modeling, for example, using ElasticNet. But if you apply ElasticNet to a large data set like this, it will end up mostly selecting cell-free RNA and microbiome features. The reason for that is that these are the two largest data sets that have tens of thousands of measurements per patient, and they're overwhelming the machine learning algorithm. You can go even beyond size. Adjusting for size is not enough. It turns out that the number of principal components that you need to account for 90% variance in these data sets is also different. These smaller data sets, even though they're small, they're measured carefully. And every feature is designed for a particular reason. So they end up having really good modularity, a lot of independent information content. So we spend a lot of time figuring out how to integrate these algorithms the right way so that it would allow us to pull information from all of them, have a higher level model that can predict the eventual outcomes that we are interested in. So using platforms like this, working with the Gates Foundation, we were able to predict preterm birth fairly accurately in the first trimester of pregnancy using data from 5 low and middle income countries in Southeast Asia and Africa. The model is looking at a steroid hormone biosynthesis pathway in urine, right next to it, the placental growth factor. That makes sense. And then if you keep going to the right, GCSF, PD-L1, IL-6, IL-1RA, the classic inflammatory module that is associated with preterm birth. This was published a couple of years ago. You can read about it in more details. Now we are in the process of expanding this to significantly larger cohorts. Next, we're going to switch gears and talk about how social determinants of health affect biological pathways. First example that I will show you is from our work on maternal stress. We administered a questionnaire measuring various aspects of stress in the first trimester of pregnancy in about 300 women. We were able to show that these stress questionnaires alone are significantly associated with preeclampsia and preterm birth. But more excitingly, when we took these models using a multitasking neural network, we were able and predicted these outcomes, we were able to show that the immune system ends up being associated with this model independently. So this hopefully points to future directions that would allow us to use interventions that can modify stress levels to modulate the immune system in the right direction during pregnancy. In a different study, we have looked at 1,500 patients in whom we had access to data from wearable devices, from a smartwatch that measures physical activity and sleep. Using a sophisticated AI platform, we were able to build predictive models that can look at the data from physical activity and sleep and estimate the gestational age of a pregnancy. That in itself is quite exciting, but more importantly, we were able to show that patients who live here, patients whose gestational age appears to be higher than it actually is, meaning that they're less active and their sleep quality is low, so they look like someone who's really pregnant, end up being at higher than actual risk of preterm birth with an odds ratio of 1.33 and a really low p-value. And more excitingly, patients whose physical activity is really good and their sleep quality is poor, resulting in the model thinking that they are less pregnant than they actually are protected against preterm birth with a really low gestational age and a really strong p-value. So our goal after this is to connect sleep and physical activity with our electronic health records, pregnancy outcomes, placenta imaging, metabolomics, and proteomics in order to understand any possible causal effects between physical activity and sleep that would allow us to modify the immune system and regulate inflammation before birth. The third project that I will show you is focused on a new taxonomy for prematurity itself. Everything that I showed you so far defines prematurity as gestational age under 37 weeks. And then we were trying to use all of these various biological modalities to predict it. But why we were using 37 weeks and why gestational age was not clear to me as a non-physician. So we looked into it, and it turns out that this comes from historic studies looking at mortality rates several decades ago, mainly in Europe. And mortality rates themselves come from neonatal morbidities. Now we have modern data platforms. We don't have to go through this simple definition of gestational age. So we asked whether we can replace all of these with a neural network with many inputs and many outputs. I'm sure you can see the similarities between these two diagrams, except that 40 years ago, we didn't have access to this type of computing power. So we did that. We took a lot of large epidemiology level data sets and introduce them to that AI pipeline. I'll show you the results in a minute. But again, the current paradigm is that term birth is after 37, preterm birth is below 37, extreme preterm birth is below 28. But in reality, we have babies that are born late and are in trouble, and we have babies that are born early and are healthy at the end of the day. So we have to come up with a new taxonomy for that. First, we started with an epidemiology level clinical data set where we had linkages to neonatal morbidities in 11 million pregnancies in California. We put all of those through a deep learning pipeline, and we showed that we are able to predict these various morbidities fairly accurately. This is a model built in 1 million pregnancies, tested in 10 million pregnancies, and we are clearly doing far better than gestational age or traditional definitions of preterm birth, extreme preterm birth, or small for gestational age. But precision and recall is not good enough for us to be able to do any type of personalized precision medicine using these models, even though it's still far better than current practice. The first step to solve that for us was to bring in biological information by combining metabolites from dried blood spots collected in every pregnancy in California. With our model, we were able to resolve our precision and recall issue. This shows that, for example, we can predict necrotizing enterocolitis close to birth. This is a gut complication that is often diagnosed several months after birth, and by then the only recourse is a surgery with poor outcomes. But here we are showing that we can predict it immediately after birth. So interventions like delayed feeding or antibiotic use can be used to prevent that eventual surgery. The next step for us was to connect all of these to electronic health records. First, we built a linkage between the Children's Hospital's electronic health record at Stanford and the adult hospital. This gave us long-term information on the mothers, including procedures, diagnosis codes, lab values, and so on, as well as long-term information on the babies from the Children's Hospital, where we are tracking all of these various morbidities in them. So again, we have the mother's electronic health record, and at some point, the newborn's electronic health record starts. All of these can be fed into a deep learning pipeline. But before we do that, we need to deal with the longitudinal nature of the data. That is done using a long short-term memory neural network that works just like your brain. When you're reading a book, you don't memorize every single word of the book. You only memorize key concepts that then you bring to the next page, and you remember maybe for a while after you are done reading the book. The same thing happens here. Memorizing the entire electronic health record of a patient is not possible. That data set would be too big, but the LSTM does a pretty good job at carrying the critical concepts forward until an eventual prediction is made. Using this pipeline, we show that we can predict necrotizing enterocolitis at birth fairly accurately, but excitingly, we can even predict it before birth. Similarly, bronchopulmonary dysplasia is a lung complication that we can predict at birth, but importantly, we can also predict it before birth. Here is an example from one patient. A red check mark indicates a diagnosis that was made for this one patient, and a green cross means a disease that they ended up not getting. And as you can see, we got every diagnosis right. But more importantly, we almost got everything right 2 weeks before birth, before there even was a baby. We already knew what is going to happen to this baby. So that's quite exciting. When you look at what the model is considering, it's looking at insulin use in the mother, antihypertensive use, history of chemotherapy, even if it was several years before pregnancy, as well as a wide range of other factors, including the status of the immune system and even social determinants of health like incarceration, homelessness, tobacco use. If you compare this network across various morbidities, you start seeing differences. So these factors are being used non-uniformly depending on which morbidity needs to be predicted. If you look at the lab values alone, you will see, for example, that mothers with a stronger immune system with higher levels of lymphocytes, neutrophils, and so on are giving birth to babies that are protected across the board against various morbidities. Similarly, mothers with a higher albumin level as a surrogate for nutrition are giving birth to babies that have better protection against various outcomes, regardless of gestational age. All right, so I'm going to stop here. Apologies that I couldn't be there with you in person, hopefully next year. Thank you for listening, and please feel free to reach out to me directly with any questions about our work on biology or AI or even indications beyond preterm birth itself. With that, I would like to thank a large group of people in the lab, our alumni, various investigators in the Prematurity Research Center, including David Stevenson, Gary Shaw, and Carl Sylvester, our colleagues at the Gates Foundation and the MOMI Consortium, Martin Angst and Brice Goudelier, who have been my co-PIs for some of our biological works, as well as various funding agencies. Thank you very much.
Welcome you all to my today's presentation. I am Professor Colonel Retired Sharmina Firdausi from Bangladesh, which is located in South Asia, and our population about 171 million. My today's discussion topics is high-dose methotrexate and leucovorin rescue therapy in childhood malignancies experience in resource-limited country. Study period was July 2014 to December 2015, and place of study was Combined Military Hospital, Dhaka, Bangladesh, because at that time I was in service. And I have done it in Department of Pediatrics Department of CMH, Dhaka. Acute lymphoblastic leukemia, that means ALL, is the most common childhood malignancy and a leading cause of childhood cancer death. Non-Hodgkin's lymphoma, NHL, accounts for approximately 7% of cancer. Osteosarcoma comprises 5% of all pediatric malignancies. There is great concern about the quality of life among the directed therapy, which is an integral part of the treatment of pediatric malignancy. The 5 years event-free survival rate is more than 80% for pediatric ALL, and due to advances in neoadjuvant and adjuvant chemotherapy have improved 5 years disease-free survival rate also for osteosarcoma about more than 60%, and for non-Hodgkin's 80 to 90%. In late 1960s, Diuresis et al. Showed that increasing the doses of methotrexate would secure new remissions in patients who had relapsed while receiving the drug at lower doses. High-dose methotrexate is a common component of many chemotherapeutic protocols for childhood malignancy, and some of them have side effects. Prominent side effects are bone marrow depression, mucositis, diarrhea, liver and kidney dysfunction, dermatitis and neurological disturbance. To minimize the toxicity of these drugs, urine alkalinization, vigorous hydration and rescue with leucovorin is needed. Facility for serum MTX level was not available at the time of my study period in Bangladesh, so aim was my study to evaluate the high-dose methotrexate toxicities by monitoring biochemical and serological markers. Inclusion criteria of ALL and NHL patients. These are the inclusion criteria: poor response to prednisolone on day 8, high-risk cytogenetics, CNS involvement, high-risk T-cell phenotyping, partial remission of bone marrow after induction, T-cell NHL, and Burkitt's lymphoma stage 4. A prospective observational study was done in 12 children with a confirmed diagnosis of ALL, NHL, Burkitt's lymphoma, non-Hodgkin's, and osteosarcoma. Diagnosis of ALL was made by morphology, immunophenotyping, and risk stratification was done by cytogenetics. Non-Hodgkin's and osteosarcoma were confirmed by histopathology and immunohistochemistry. Each patient received 4 cycles of high-dose MTX, total 48 cycles for 12 patients. In each course, they received high-dose MTX according to the protocol. All the cycles met the prerequisite criteria of prehydration, urine alkalinization, duration of methotrexate infusion, and appropriate leucovorin rescue. And what was the result? This is the sex distribution of study group patients, and this is the percentage of various diseases. And now I want to show the toxicities of high-dose methotrexate in 48 cycles. Among the 48 cycles, we found that neutropenia was the most common toxicity, about 83%. After that, vomiting was 70%, mucositis was 56%, and we found that raised serum transaminase level only 12%, and only 2 patients had transient impaired GFR. Frequency of what type of toxicity was frequent at that time? Vomiting and diarrhea were most frequent in cycle 2. Mucositis and fever were most frequent in cycle 1. Raised serum transaminase in cycle 3, and 2 patients had less than 100 creatinine clearance. And due to percentage of neutropenia was very high, so we compared other toxicities in relation to neutropenia. So we found that along neutropenia, vomiting was about 75 patients also have vomiting. Mucositis have 57% patients. Fever had 37%, and raised transaminase level 12.5% of patients, and thrombocytopenia only 22% patients. So we can say that the administration of high-dose MTX therapy was found to be safe without any life-threatening adverse effect in a developing country like Bangladesh. Trained nurses, medical staffs, including meticulous monitoring of treating oncologists, is the mainstay of early detection and prompt management of complication if arise. And this is the current status. Our total patient number were 12. Among them, 9 are happily surviving, and their event-free survival rate above more than 5 years. So 9 are happily surviving, I again can say confidently, and among them 3 expired: 1 osteosarcoma due to disease process, 1 T-cell ALL due to very early relapse, and 1 B-cell ALL due to early relapse. Thank you very much. Thank you all for patience hearing.
In the name of merciful God, I want to present my research with title The Effectiveness of Conventional Cognitive Behavioral Therapy and its Computerized Version on Reduction in Pain Intensity, Depression, Anger, and Anxiety in Children with Cancer, a randomized controlled trial. It was actually the work of my doctoral thesis, so that I can explain more about this. What motivates me to do this was that one day, together with my brother's family, we went to the hospital for an eye examination, and my nephew, who was 1 year old that time, had come to hospital for cataract surgery. Unfortunately, the behavior of medical staff showed a disregard for the children's age and anxiety problem, and this disregard made my nephew develop a phobia of medical procedures. And it was there that I decided to help the children who are in hospital and especially suffering from pain. Maybe those who work in the treatment field are not very aware that diagnostic and treatment processes can be stressful for kids. This made me decide to apply my knowledge in field of psychology to help this group of kids, and so I started. I studying and found that the computer program game can be used for this aim, and I use a computer intervention make it possible to help a lot of people. It creates an opportunity for people to use this service who don't even have access to simple psychological service. So I came up with this idea and creating a computer program to help this group of kids. Because creating this computer program required a lot of expertise, such as directing, imagining, sounding, Photoshop animation, autoplay programming, and its high cost of cooperation from other fields at that time, I decided that I would learn those by myself. The next point is that when I started my work, using the internet and the computers was not very common for children. So I faced a bit of guards, and some didn't believe in its effectiveness. But thanks God, the results show that this work can help a lot of children with cancer. Now I wanted to explain to you more about what we did in this program and what happened. Since last decade, the epidemiology of pain in children is considered. Childhood pain is important because of the challenge in daily life and its effects on the future. For instance, children experiencing abdominal pain are at increased risks of somatic symptom, mental disorder, and hospital admission for unexplained medical reasons during adolescence. Children with cancer often experience pain due to disease progression or treatment side effect. The prevalence of pain in such children is estimated at 25 to 50% depending on the stage of disease and the cause of the pain. The memory of pain experiences in children may affect the way they react to later painful experiences and accept medical interventions. What is remembered about past painful events plays a pivotal role in predicting and responding to future problems. Painful procedures are accompanied by negative emotions The prevalence of anger and depression is higher in individuals experiencing chronic pain compared with healthy people. Chronic pain is common in children. Significant portions of children receive inadequate assessment and management of pain in hospitals. It particularly occurs in the context of procedural pain. Experiencing pain of greater than moderate in intensity in childhood is associated with short and long-term adverse physiological and psychological effects. Uncontrolled pain in newborns can change the process of pain, and perception can affect physiological, social, and neurocognitive development outcome. Due to advancement of technology and the needs of healthcare, various therapeutic methods such as internet-based and computerized CBT are developed. Internet-based therapy is effective in several disorders such as anxiety and depression. Interventions applied to pain management are generally expensive. CBT is one of the most popular and effective pain management therapies utilized in many psychiatric disorders such as depression and anxiety. It is provided that CBT is an acceptable intervention for the ones experiencing pain. The basic principle of CBT for controlling pain include patient-based assistance to indicate how behavior and cognition can affect the perception of pain. During treatment, patients are encouraged to learn coping skills and restructure cognition and apply coping skills to wide range of daily activity. One of the negative aspects of treatment with CBT is often related to developing countries. High cost and inaccessibility make it an unavailable treatment. As the internet spreads across the globe, CBT can implement as internet-based intervention. The use of technology can eliminate almost all of the above-mentioned obstacles. Family can use computer-based program at home for the sake of confidentiality. They receive treatment without fear of being seen in mental health clinics. The experience of pain in cancer is widely recognized as a major threat to the quality of life. Relief of pain is a priority in oncology care. By the disease progression, pain management should be presented at a different level from the disease onset, even for those who are in the final stage of life. Cancer is one of the most painful chronic disorders in children because of the significant impact of childhood cancer on both the patients and their families. A computer program is designed to help children to cope more effectively with the circumstances. Because of some limitation in the availability of psychological services for such patients, CCBT may be suitable alternative to conventional CBT due to more accessibility. The study objectives were described to the parents, and written consent was provided by the parents for ensuring the presence of the participants. The subjects signed an agreement. The CBT group attended 6 45-minute psychological sessions. The CCBT group received a guidebook including parents section and homework, as well as compact disc containing the contents of all 6 CBT sessions. Psychoeducation and training were provided via text, animation, and games. After last session, in the 6th week, the participants were re-evaluated. The therapeutic package was designed based on the article in this area and the content of Handbook of Pain Management. 3 clinical psychology experts confirmed the content validity of package. Table 1 shows the mean and standard deviation of the variables in pre- and post-tests. In addition, MANCOVA was used to examine differences among the 3 groups. The result of Table 2 show no significant differences between the 2 intervention groups and the control group in terms of depression, anxiety, anger, and pain. In other words, the study variables were homogeneous in the 3 groups in the pretest. The result of Table 3 show a significant difference between the 2 intervention and control groups in the post-test in terms of depression, anxiety, anger, and pain. In other words, CBT and its computerized version could reduce depression, anxiety, anger, and pain in the post-test. As Table 4 shows, the 2 methods of intervention used in the present study did not differ significantly in terms of changes made into the dependent variable. However, it is shown that in CBT, the difference of anger score between pre- and post-test was greater than that of CCBT, which means the CBT was more effective in reduction of anger. Because of limitation in time, I summarize the result and conclusion. The finding of the study indicated that both intervention could reduce negative emotion associated with cancer, for example, pain, anger, anxiety, and depression, in children compared with control group. In addition, there were no significant differences between 2 intervention groups. It means both interventions were useful to reduce pain and enhance adjustment. The CCBT can be authorized in case of no access to psychological and psychologist service. Thank you for your attention.
Title Pathophysiology of the influence of aqueosus diuresis with molecular hydrogen saturation in acute kidney damage. My name is Yuri Rokhovy, affiliation Doctor of Medical Science, full professor, head of the Department of Pathological Physiology, Bukovinian State Medical University, Chernivtsi, country, Ukraine. Please, next slide. Relevance of the topic. It is known that molecular hydrogen has anti-inflammatory effect, inhibits oxidative stress, suppresses the development of atherosclerosis, prevent cognitive impairment, has hepatoprotective effect, protect against acute kidney injury, inhibits allergic reaction. Molecular hydrogen can be used as an effective antioxidant therapy due to its ability to diffuse rapidly across membranes. It can reach and react with cytotoxic reactive oxidant species such as hydroxyl radical and peroxynitrite, and cerebrally protect against oxidative damage, inflammation, pyroptosis, and apoptosis. Please, next slide. Purpose of the work. They find out the effect of a solution of negative redox potential with a molecular hydrogen saturation of 1.2 ppm on the functional and biochemical process of the kidney during acute hemic hypoxia of medium severity, splitting of oxidation and phosphorylation, no reflow syndrome in the early polyuric stage sublimate nephropathy with a hyposodium diet and irritable bowel syndrome with constipation and diarrhea. Please, next slide. Method of the study, experimental, 120 sexually mature male rats weighing 0.16 to 0.2 kilogram, clinical studies, 60 patients, irritable bowel syndrome. A method used pathophysiological, physicochemical, physiological, gametological, histoenzymochemical, microbiological, general, clinical, immunoenzymatic, chemiluminescence, biochemical, chemical, statistical. Please, next slide. As the principle of operation of the molecular hydrogen generator blue water 19S of the new generation South Korea. Advanced proton exchange membrane, which is also a PEMSEE, solid polymer electrolyte, molecular hydrogen concentration 0.9 to 1.2 ppm, redox potential -100 to -350 millivolt. Molecular hydrogen is a strong antioxidant, 170 times more effective than ascorbic acid. Molecular hydrogen helps the body to produce its own antioxidants. Unlike other antioxidants, molecular hydrogen has the unique property of penetrating into the focus of edema, ischemia, through the blood-brain barrier into mitochondria and other organelles of cells. Let's see on this picture. The slide shows the values of the redox potential millivolt of water and urine at a water load of 5% of body weight with urine collection for 2 hours in rats. First, ordinary tap water. Second, water of negative redox potential treated with microhydrin. Third, water of negative redox potential with additional saturation with molecular hydrogen. Pay attention to the decrease in the redox potential of urine to negative values. Please, next slide. The effect of induced diuresis with water of negative redox potential with molecular hydrogen saturation compared to water of negative redox potential without molecular hydrogen saturation, microhydrin, on the functional state of the kidney in intact rats showed an increase in glomerular filtration rate, proximal reabsorption of sodium ions, and decrease in the degree of proteinuria. Please, next slide. We have established the absence of activation of the dysregulatory mechanism of basal tone of renal cortical vessels and the water-induced diuresis of negative redox potential with hydrogen saturation compared to negative redox potential without hydrogen saturation using microgidrin, which substantiates the possibility of using water saturated with molecular hydrogen in the daily diet. Please, next slide. Let's see, we can see no reflow syndrome, failure to restore blood flow during reperfusion. No reflow syndrome develops in the cortical region of the kidney 72 hours after mercury dichloride administration in rats at the polyuric state of acute kidney injury with hyposodium ions. 100% norm, ischemia 10%, no reflow 60%. Adhesion and aggregation of red blood cells and platelets, microthrombi, endothelial swelling, edema, action of thromboxane A2. Please, next slide. Mechanisms of the no reflow phenomenon. Let's see on this picture, we can see localized endothelial swelling, erythrocytes, diapedesis, and fibrin formation, swelling of the surrounding tissue, thrombus, aggregation of red blood cells, columns, compression, platelets, neutrophil adhesion, endothelial swelling, capillary lumen. Please, next slide. The slides demonstrate the effect of a water load of 50% of body weight with saturation of molecular hydrogen on the functional and biochemical processes of the kidney in the development of no reflow syndrome in rats with improved proximal sodium ion transport, beta-2 microglobulin, energy metabolism by the activity of succinate dehydrogenase in the cortical region of the rat's kidneys, antioxidant effect, and restoration of fibrinolysis in the renal papilla. Please, next slide. The effect of water loading with saturation with molecular hydrogen showed the restoration of diuresis, glomerular filtration, inhibition of sodium ion excretion in the no reflow syndrome in rats. Please, next slide. The effect of water loading with saturation with molecular hydrogen showed an anti-edematous effect at the level of 7 areas of the kidney in the no reflow syndrome. Effect of water load of 50% of body weight with molecular hydrogen saturation of 1.2 ppm on the degree of edema of 7 kidney areas and the hyposodium diet with the urine collection for 2 hours at the polyuric state of sublimate nephropathy with the development of no reflow syndrome in rats compared to control animals with a load of ordinary tap water, 1 taken as 100%, 2 cortex 1, 3 cortex 1 plus molecular hydrogen, 4 cortex 2, 5 cortex 2 plus molecular hydrogen, 6 otostrip water medulla, 7 otostrip water medulla plus molecular hydrogen, 8 inner-strip water medulla, 9 inner-strip water medulla plus molecular hydrogen, 10 inner medulla 1 plus molecular hydrogen, 12 inner medulla 2, 13 inner medulla 2 plus molecular hydrogen, 14 inner medulla 3, 15 inner medulla 3 plus molecular hydrogen. Please, next slide. We have shown the protective effect of molecular hydrogen and the polyuric state of sublimate nephropathy on the rupture of large and small vicious circles formed in the case of proximal tubular damage in the setting of no reflow syndrome. Let's see the image of the proximal tubule. enzymatic fibrinolytic activity decrease, proximal reabsorption of sodium ions decrease, renin-angiotensin-aldosterone system increase, glomerular filtration rate decrease, intoxication, lipoperoxidation increase, syndromes, sodium loss, no reflow, proximal reabsorption of sodium decrease, reabsorption of beta-2 microglobulin decrease, activity of succinate dehydrogenase in renal cortex decrease, edema of the kidney, cortex 1, 2, inner strip, outer medulla, outer strip, outer medulla, inner medulla 1, 2, 3, lipoperoxidation increase, ratio potassium to sodium decrease, renal cortex, damage of the proximal tubule, a large vicious cycle, and we can see 3 small vicious cycles. 1 small vicious cycle, second small vicious cycle, and third vicious cycles. Please, next slide. The acute hemic hypoxia of moderate severity, the use of a solution of negative redox potential with saturation with molecular hydrogen due to its antioxidant, cytoprotective, energetic properties, improves the condition of the proximal tubule, reduces the manifestations of tubular proteinuria, increases the activity of succinate dehydrogenase in this part of the nephron, and reduces the potassium lowering effect of aldosterone by inhibiting the activity of tubuloglomerular feedback and the intrarenal renin-angiotensin aldosterone system. The use of a solution of negative redox potential with saturation with molecular hydrogen due to its antioxidant, anti-inflammatory, nephroprotective properties has a protective effect on the kidney and reduces the increased level of tumor necrosis factor alpha in the blood plasma, lysis of azocollagen, azoalbumin, azocasein, and lipid peroxidation product of malonaldehyde and DN conjugates in acute hemic hypoxia, moderate severity. Please, next slide. Under condition of renal hypoxia due to the splitting of oxidation and phosphorylation process, the use of a solution of negative redox potential with saturation with molecular hydrogen due to its antioxidant, cytoprotective, energetic properties improves the condition of the distal tubule, reduces the manifestation of tubular proteinuria, increases the activity of succinate dehydrogenase in the proximal nephron, and reduces the concentration of potassium ions in the urine against the background of a decrease in the redox potential of urine to negative values. The use of a solution of negative redox potential with saturation with molecular hydrogen due to its antioxidant, anti-inflammatory, nephroprotective properties has a protective effect on the kidney and reduces the increases level of pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin-1 beta, interleukin-6 in blood plasma, total enzymatic, non-enzymatic fibrinolytic activity, lipid peroxidation product, malonaldehyde, DN conjugate, oxidative modification of protein in the renal cortex in case of hypoxia due to spilling of oxidation and phosphorylation process. Please, next slide. The protective effect of molecular hydrogen in irritable bowel syndrome with constipation and diarrhea leads to the elimination of dysbiosis, intoxication syndrome, lipid peroxidation, improves the general condition of patients on the Likert scale, reduces the degree of proteinuria, and restores the fibrinolytic activity of urine. The protective effect of molecular hydrogen in irritable bowel syndrome with constipation and diarrhea improves the functional state of the proximal renal tubule due to its higher permeability and selective antioxidant activity to neutralize hydroxyl radical and peroxynitrite, which helps to break large and small vicious cycle of the combined pathological process of intestinal and renal damage. Please, next slide. We can see a break in large and small vicious cycle with the help of molecular hydrogen in the correction of proximal tubule and intestinal damage in irritable bowel syndrome. Let's see, damage of the proximal tubule, fibrinolytic activity of urine decrease, proximal reabsorption of sodium decrease, renin, angiotensin, aldosterone system increase, glomerular filtration rate decrease, intoxication, lipid peroxidation increase, tumor necrosis factor alpha increase, interleukin 1 beta increase, interleukin 6 increase, inflammasome, energy intestine deficiency, bifidum decrease, beta-lactase decrease, lipopolysaccharide increase, inflammation. Lipoperoxidation increase, damage of the proximal tubule, large vicious cycle, and we can see 3 small vicious cycles. Once vicious cycle, 2 vicious cycle, small vicious cycle, and third vicious cycle. Please, next slide. Next slide. A conclusion. Our research has revealed the pathogenesis of the effect of a solution of negative redox potential with molecular hydrogen saturation on the functional and biochemical process of the kidney in moderate acute hemic hypoxia, hypoxia due to the splitting of oxidation and phosphorylation process, nodal flow syndrome at the early polyuric stage of sublimat nephropathy under hyposodium diet and irritable bowel syndrome with constipation and diarrhea, and the corrective protective effect of this agent on the studied pathological process was found. Please, next slide. Thank you for your attention.
Thank you for presentation, Dr. Yuri.